Thanks, Ryan. Good afternoon, everybody, and welcome to today's webinar, our next session of the Nurture Me webinar series, Cannabis Use During Pregnancy and Postpartum, featuring Dr. Elaine O'Connor. My name is Hannah Winkelhofer, and I am the ACE and SCI Prevention Coordinator here at the CDC. Before we introduce Dr. O'Connor, just a little bit of housekeeping. Today we're using Zoom's webinar format, which focuses on the presenter. However, you are encouraged to share questions with Dr. O'Connor to answer in the Q&A section, which I will be monitoring throughout the webinar. If you have any technical questions or would like to add to the conversation, please direct your comments into the general chat section. Near the conclusion of the webinar, Ryan Nealon from AdCare will share an evaluation link for today's presentation. We really appreciate you taking a moment to provide your valued feedback, which helps ensure that we are providing quality content. Also, Ryan will be sure to email your participation certificate within 10 business days. And now it is my pleasure to introduce our presenter. Dr. Elaine O'Connor is the Director of Perinatal Addiction Medicine at Maine Medical Center and is the Medical Advisor of the Maine Maternal Opioid Misuse Maine Mom Initiative, a 5-year, $5 million federal grant to expand access to substance use disorder treatment for pregnant and postpartum individuals in Maine. Dr. O'Connor also co-chairs Maine's Opioid Response Clinical Advisory Committee, which advises the governor's opioid response director on clinical and public policy issues. She has more than 15 years of experience in addiction medicine in a variety of settings, including the design and implementation of an extended release buprenorphine pilot at Somerset County Jail, rapid access to substance use disorder treatment in emergency departments through Maine Medical Association's Project RISE, as well as extensive experience caring for pregnant patients with substance use disorder in both the inpatient and outpatient settings. Dr. O'Connor lectures regionally and nationally and has trained more than 100 family medicine and obstetric resident physicians. She is a core faculty member of Maine's only addiction medicine fellowship program. And finally, Dr. O'Connor has published numerous peer-reviewed articles on maternal and infant outcomes following substance-affected pregnancies, including child welfare implications, as well as the care of pregnant patients with substance use disorder who are incarcerated. Please join me in welcoming Dr. O'Connor.
Great, thank you so much. Good afternoon, everybody. Delighted to be with you today to talk a little bit about cannabis use during pregnancy and postpartum. This is a tough topic for both, I think, providers and patients alike. A lot of confusion, uncertainty, misunderstandings around this. And so hopefully we'll go through the literature, some of the evidence, and some of my clinical experience, and we'll just talk through it. And I'll leave plenty of time at the end for questions. Next slide, please. Quick disclosure, so I have no actual or potential conflict of interest in relation to this presentation. I do just want to acknowledge that the use of cannabis is kind of a polarizing topic for many. And I just want to acknowledge that the focus of this lecture is really around pregnant and postpartum patients with substance use disorder. So I want to be clear, I'm not an expert in medical cannabis. This is not a lecture on medical cannabis. This really focuses on the complexity of caring for patients who are pregnant and postpartum who are using cannabis really within the context of substance use disorder. So this is very separate from somebody who may have a medical indication being followed by somebody who specializes in medical cannabis. This is very specific to a unique population. So I just want to kind of acknowledge that and disclose that up front. Next slide, please. So we're going to discuss the prevalence of cannabis use during pregnancy and postpartum, as well as the challenges overcoming the perceived safety of its use. Very common for folks to feel that it's safe. We're going to talk about the potential health implications of cannabis use during pregnancy and postpartum, including while breastfeeding. And we're going to talk about some of the reasons that pregnant and postpartum patients tend to use cannabis, as well as strategies for talking with folks about their cannabis use in the perinatal period. Next slide, please. So I always start with what is cannabis, because I think it's confusing for a lot of folks. People don't know sort of what is the primary plant versus what's in the plant, and which has certain effects and which do not. So cannabis, when you say the word cannabis, it actually refers to the plant itself, while THC, which you probably hear of fairly frequently, is a specific chemical compound within the plant, or cannabinoid, that's primarily responsible for its psychoactive effects. So the impact that it has on the brain is primarily from the THC. You also hear about like CBD. People will ask, what's the difference between THC, CBD? It's also a cannabinoid, but it doesn't produce the high, quote unquote high, and it doesn't have the psychoactive effects. There is a lot of cross-reactivity on drug screens, particularly on the immunoassay, or kind of the initial screens. So commonly, if folks aren't allowed to use THC or cannabis for like a drug court, or situation that they're in, we sort of discourage the use of CBD as well, just because of that cross-reactivity in drug screens is fairly common. THC is also highly lipophilic. So in other words, it's stored in the fat cells in the body, and it's distributed very rapidly through the brain. One really important point to note is both regulated and illicit cannabis supply have become more potent over time. I was reading an article this morning. I was telling the folks before we started that we've seen an increase maybe 3 times the potency over the last decade or two. So it's much stronger than it ever was before. And so part of the challenge with that is the research around it probably lags the actual effects of the potency that we're seeing now, because it just continues to become more potent over time. Cannabinoids are readily absorbed through the lungs and GI tract. The half-life is about 20 to 40 hours in occasional users, to really many days in heavy users, and we can see it take up to 30 days to clear from the system in heavy users. So again, not uncommon for folks to actually stop using cannabis and then have a lengthy lag period before it's completely out of their system, again, because it's stored in a variety of their fat cells. So that can be confusing for folks, because people may say, well, I'm not smoking anymore, but their urine may still have it in them or in it. So it's important to sort of have those conversations. People use cannabis in a lot of different ways. So they may smoke it in joints, blunts, pipes, or bongs. You hear about vaping cannabis a lot, which is vaporizing it. You hear about ingesting through edibles, so also another common way. So it could be cookies, brownies, candies, a whole host of different things. There's also cannabis-infused tinctures. And I've seen more of it actually recently with applying topically through oils on the skin. So people are being exposed to it in a variety of different ways. Next slide, please. So cannabis use during pregnancy and postpartum. So, and I put illicit in quotes because as we've talked about, there's both sort of, there's recreational, there's medical, there's also sort of more of the quote unquote illicit market. It's the most common used illicit drug during pregnancy, but many states do have medicinal, others recreational, others both. We do think that actually the use of cannabis during pregnancy is probably second to alcohol overall, which I think always makes me wonder how many cases of alcohol use during pregnancy we're actually missing, because again, this is widely available, both of those different things. In Maine, we have both medical and adult use recreational marijuana. They're both legal. Cannabis dispensaries are common. You see those when you drive down the street. Medical marijuana may also be provided by a caregiver, so you've probably heard that term, who's registered to cultivate and provide marijuana to the patient. I raise this just because, again, the confusion around it's a medical, some people have a medical license for cannabis. They kind of, the perception that it's safe, particularly when we've got a caregiver, and we as medical folks are often called caregivers. So there's just a lot of confusion around the safety of this during pregnancy. The frequency of cannabis use in pregnancy varies depending on the population of folks you're looking at. So some studies say 2 to 5%, others say up to 15 to 30%, depending on the population being studied. Up to half of the individuals who use cannabis prior to pregnancy continue to use it during pregnancy. We do know that the COVID-19 pandemic had a pretty remarkable impact. So prenatal cannabis use increased by about 25% when compared to the 15 months before the pandemic. That's pretty much an issue with lots of different substances during the pandemic. People were isolated, they were lonely, and they were certainly using more substances of all kinds during that period. Up to 1/4 of those who test positive for cannabis at delivery also meet the criteria for cannabis use disorder. So again, there's sort of a whole spectrum of cannabis use, from infrequently small-ish amounts to sort of daily heavy use that really can impair folks' lives. Next slide, please. So cannabis use disorder is diagnosed like all the other use disorders. So if you look in the DSM, we have the same sort of criteria for diagnosing cannabis use disorder as we would for, say, opioid or alcohol use disorder. It's a clinical diagnosis defined by a problematic pattern of cannabis use leading to significant impairment or distress. So again, like with all other substances that someone might develop a use disorder of, it's typically a persistent use despite negative consequences. Including physical and mental health problems, social or interpersonal difficulties, occupational educational challenges. And again, like all other use disorders, it can range from mild to severe. So it really, people teeter into the use disorder category when it really starts impairing their lives. So when they need it to be able to function, or they're not able to function because they're using so much of it. And the reactions are delayed, or maybe they're driving impaired, or they're unable to perform their tasks at work because of being impaired. It's really common in women with other use disorders. So I see this all the time that folks with other use disorders are also using cannabis. So for folks with an opiate use disorder, it's about 43% are also using cannabis. Patients with an opiate use disorder and alcohol use disorder during pregnancy, it's about half, so 52%. And those with an alcohol use disorder only, it's about 46%. So really pretty much half of those with another use disorder are also using cannabis. Different perceptions around safety of different things. And as always, as with everything in pregnancy, determining the specific effects of cannabis use is hard because you have these things called confounders. So when you look at the research, there's all these other things that can contribute negatively to pregnancy outcomes. So it could be other substance use, it could be poverty, nutrition, concurrent tobacco use. So it's sometimes hard to pull out the very specific effects of cannabis. I will say we probably have more data with cannabis use because there's more people purely using cannabis during pregnancy. For example, most of my folks with opiate use disorder may also be, smoking cigarettes, or they may also be using stimulants, or they may be unhoused, unsheltered, hungry. So there's lots of other things that are contributing. But we do have more data around people who are just using cannabis, again, in part because it's viewed as safe. The other thing is because of how we study pregnant patients, we don't sort of randomize them into trials. It's really subject to recall bias. So if you ask somebody a year after their pregnancy, how much cannabis were you using at week 12? They probably don't remember because it was a year ago. The other thing is that they may not report that. I mean, if things that are viewed negatively by society in general, folks who are they're concerned about a child welfare report or something like that, people may not report their use. So there's a lot of reasons why we may not know the specifics of this impact during pregnancy. Next slide, please. So first off, like, what are some of the maternal impacts of cannabis use in pregnancy? So I tried to sort of pull out kind of the maternal piece separate from the infant piece during pregnancy, and what are some of the impacts. This is a pretty recent study, which is a very strong study. So it looked at over 300,000 pregnancies and found that cannabis use during the prenatal period was associated with a greater risk of gestational hypertension, a greater risk of preeclampsia, a greater risk of either gaining too much or too little, or placental abruption. So these are all really serious potential complications of cannabis use during pregnancy. And I would say this data is emerging even more recently. We have a little bit more data on some of the impact of the use on the infant, but this is really looking at a large review of a number of women and the impacts that it had on their pregnancy. I also really wanted to point out, so this next study is, again, another review study of 124 studies. This is specific to some of the mood and psychological impacts of cannabis, and I really want to stress the importance of that. I couldn't find a specific study talking about the psychological impacts specific to pregnant women with cannabis, but I just wanted to point out this study. Again, it's in the references if anybody wants to read it. Found that cannabis use was associated with several behavioral issues, including cognition, motivation, impulsivity, mood, anxiety, psychosis, and intelligence, as well as psychosocial functioning. So there does seem to be also the strongest negative effects for psychosis and psychosocial functioning. So I just want to call attention to that. And I was reading more about, like, why does this happen? And we think as the THC has increased in potency, the way it interacts with the amygdala, which is sort of the part of your brain where it may create, or where it regulates sort of anxiety and fear, you tend to see, as the THC has increased, kind of an overstimulation of that part of the brain. And people really do tip into sort of paranoia and psychosis fairly easily, in a fairly dramatic way. And this is something that, 5-10 years ago, I would have said, oh, I don't see that. We certainly saw some of the stimulant-induced psychosis, but we hadn't really seen any of the cannabis-induced psychosis. And I was talking to some folks at a conference not long ago, and just, some of the child welfare cases that actually involved really cannabis use that contributed to psychosis in the parent, and certainly the negative impact that might have, obviously, on parenting. So evidence suggests that the frequency of cannabis use, THC but not CBD content, age of onset, and cumulative cannabis exposure can all contribute to adverse outcomes in individuals without a pre-existing medical condition or psychiatric disorder. So these are not folks that necessarily have an underlying risk of having psychosis or anything like that, or an impact on psychosocial functioning, which is just your sort of ability to perform your daily tasks, go to work, go to school, parent your child. So these are folks that are at higher risk, even despite not having any other risk factors per se. So cannabis use can really negatively contribute to mental health and psychosocial functioning. Next slide, please. So yeah, there's this other thing called cannabinoid hyperemesis syndrome. I don't know if folks have heard of this. Really common in pregnancy, in particular, because there's just so much nausea in general in pregnancy. So this is a condition in which a patient experiences cyclical nausea and vomiting and abdominal pain after using cannabis. So it's characterized typically by people who are kind of longtime users of cannabis. That predates the onset of the illness, a cyclical pattern of kind of increased vomiting every few weeks to a month, at which time the patient is still using the cannabis. And then really the resolution is only after one either cuts down or completely ceases using cannabis. One of the most important questions kind of diagnostically, if you're trying to tease out this cannabinoid hyperemesis syndrome, is that their symptoms are actually relieved by hot baths or showers. So that can almost be completely diagnostic in some cases. It's not totally clear why that happens. It could be changes to stimulation of receptors in brain, impact on the hypothalamus, or sort of altered blood flow. But patients who have this will very often say, oh my God, the only time I feel better is when I get in the shower, or when I take a hot bath, then I don't feel as nauseous. Patients are super confused by this diagnosis all the time because they feel like I'm nauseous, I'm vomiting, therefore I need to smoke more pot or use more cannabis. And so that just only makes things worse. And so you have to really back out and talk to people about this is a very specific, unique syndrome to the use of cannabis. And oftentimes, I have a patient that was supposed to come in yesterday. I was looking forward to having this conversation with her, but I think this is what's going on with her. And you see the kind of THC or the levels in the urine going way up. So I think what's happening is she's using more and more as a means to try to reduce her nausea when it actually is probably making it worse. And so then we end up trying to manage it with a bunch of different medications, which you can use and it will help. But it really, the definitive treatment for this is to really just scale back the marijuana use as much as you can overall. Next slide, please. So thinking about the impact of in utero exposure to cannabis on the infant, we do have some good data from animals where THC exposure during pregnancy disrupts brain development and function. There's also a fairly large study, again, of over 300,000 infants, about 6% of which were exposed to cannabis in utero. And after adjustment for potential confounders, so again, all those other things that can contribute to a negative pregnancy outcome, it was found that in utero exposure to cannabis was associated with greater odds of being low birth weight, small for gestational age, preterm birth, and NICU admission. There was also what we call a dose-response relationship for low birth weight and small for gestational age. So what that means is the more cannabis that you're using kind of along a linear line, the higher the risk for those adverse outcomes. So it's really kind of a stepwise approach that you saw. The more cannabis that folks were using, the higher the risk of being low birth weight or small for gestational age. Next slide, please. Oop, I think there's one back. There we go. So prenatal cannabis use and ADHD and ASD. So again, another potential, this has probably gotten more, I won't say press, but more attention maybe than some of the other issues, that there's really a question about this kind of ongoing impact for kiddos born exposed to cannabis. What are the long-term implications from a mental and behavioral health perspective? So this was a really good study. I put the link or the note of which study it was right down there in the bottom from 2024 that looked at 14 primary studies, consisting of 10 that were on ADHD and 4 on ASD, which is the autism spectrum disorders. with a total of over 200,000 patients, and really underscored the increased risk for ADHD and also autism spectrum disorders compared to their non-exposed counterparts. And again, this study was able to adjust for some of the other confounders that might increase the risk for these things, like mental health problems, maternal mental health problems, alcohol use, tobacco smoking. So it didn't change the outcomes even when all those things were controlled for. So I think a really important piece as well. And I think this can be a helpful conversation with patients, because a lot of my patients started using substances because of their own untreated mental health disorders or the struggles they had with mental health disorders. So I think sometimes it can really lead to behavior change because they think, well, I don't want to, create challenges for my own infant because I know how hard this was for me to deal with my ADHD or my depression or something like that. So it can be kind of an important teaching point as well. Next slide, please. This is a nice slide. I don't necessarily hand this out to patients because I wouldn't want to necessarily scare people, although I have given it out before. And again, I put the link for this particular picture image. And I think what is helpful is it really just talks about the potential impacts really over the course of the adolescent, the infancy, the childhood, and the adolescence of the kiddos that were exposed to cannabis during pregnancy. So attention deficits that we see, deficits in verbal and perceptual skills, reasoning, so really any kind of cognitive functioning, executive functioning, and again, probably an earlier risk for their own substance use. So it's just helpful to sort of see it over time, and you can really kind of describe that or pieces of that if that's helpful for your patients. Next slide, please. So why do pregnant women smoke or use cannabis? And this is, I think, where we can really have a positive impact. So there's this really strong perception that there's no risk to regular cannabis use. And that, in fact, has increased about threefold among reproductive age women over that 10-year period. It's definitely what I hear. People come in, very interested in cutting back on their stimulant misuse or their opioids or, alcohol, even cigarettes. But there's really this perception it's a plant, it's safe. I have a medical card, it must be safe. My friends all used it during pregnancy and they didn't have any negative outcomes. And so there's this really strong belief that there's no risk to its use. Up to 70% in this study said, there's no risk or a slight risk of harm if you use it only 1 to 2 times per week during pregnancy. And in fact, those living in urban areas who are younger with lower income and education use more cannabis and are less likely to view it as dangerous. So some of the reasons people use cannabis during pregnancy is what they sort of called in the study health management. So it could be things like morning sickness, nausea, pain, sleep. Sometimes people swap to cannabis when providers stop psychiatric medications. So that's a really important point. It's not uncommon for folks to become pregnant. People be alarmed about, oh my goodness, you're on some psychiatric medications. And I see so many of them stopped, or also potentially like the conversation is like, well, this could be unsafe or might be unsafe. And so people are almost discouraged from taking the medications during pregnancy. And then they end up sort of swapping to something else to help with their mood. And I'd really like to see a more shared decision-making of what is best, as we certainly know that untreated mental health issues during pregnancy lead to their own complications. So it's really needs to be a conversation, but you'll see people say, well, I stopped my sertraline and I'm now using cannabis because there's a perception that the cannabis must be safer than the sertraline. And so that's a really important educational point as well. Again, they may also use more cannabis because they're trying to cut back on maybe the opioids that they're using. So again, this perception is that it's safer than, the other drugs that folks might be using, or than the prescribed medications. And it may, in some cases, be safer than the other drugs, but certainly almost never safer than the medications that somebody would prescribe. I mean, there's certainly plenty of medications that are unsafe during pregnancy, but of those that folks are prescribing, are almost surely the better option. Next slide, please. So there's a nice study that looked at sort of, again, why folks use cannabis during pregnancy. Some women use it for sensation seeking, such as calming them down or dealing with life or being able to tolerate a lot of things. Patients often do not disclose use for fear of CPS reporting. So people are confused about whether or not this will result in a child welfare report, stigma from providers. Patients also report they get mixed messages from providers. While other providers don't ask about cannabis at all, I see this all the time. So people are getting very mixed messages from providers of all sorts that, cannabis is fine during pregnancy, or we don't need, I had a colleague say, I have a patient who's using cannabis. When should I tell her to stop using if she wants to breastfeed? And I sort of had to sit back and go, well, wait a minute. We don't really want her using cannabis at all. So again, sort of perceptions about it might be safe at certain points, not safe at others. Women really feel that they're not given adequate education to make an informed decision. And then this particular study, which I found, concerning, is that the women were asked, like, where do you get the most reliable information about cannabis use during pregnancy? And they really clearly said the internet or online literature, that was actually a term that was used in the study, was the most reliable source of information for many patients. And in fact, healthcare providers like us were not the preferred source of information because of a lack of clear information. So they're getting kind of mixed messages depending on who they ask. And I hear this again, like I said, all the time. Oh, I asked this doctor and they said it was okay. And that other one said no. Fear of judgment, that they're using something during pregnancy, or fear of punitive responses. I think, when people become pregnant, there's that strong overlay of like, am I going to get reported to OCFS? Like, what is that going to look like? And it really motivates people to not seek care or to not be completely forthcoming with their challenges, because I think they're fearful that if they are, it will increase the likelihood of child welfare involvement. And so unfortunately, we really kind of discourage seeking care, which is not good, because we could help folks, particularly when you have a situation like the hyperemesis thing. Their use may really be negatively contributing in a variety of different ways. Next slide, please. So this is, again, I pulled that from the study that I referenced, the Van Stone study, and it just looks at some of the reasons why people are using cannabis during pre-pregnancy, pregnancy, and lactation. So you see a pretty strong movement away from sensation seeking during pregnancy. So people are really trying to cut back on that, a much greater sort of movement toward symptom management of, nausea, again, sleep, anxiety. And again, it pretty clearly, according to the literature, makes the anxiety worse long term if people are using it for anxiety. It's often the case that in that, immediately following cannabis use, the anxiety might get a little bit better, but the long term occurrence is actually probably worse. The other thing people use cannabis for a ton is nausea. And you'll often see, particularly in my patients who are, many patients who have opioid use disorder, in addition to using the cannabis, and they're pregnant. And these folks are really, really constipated because both the pregnancy and the opioids make them very, very constipated. So again, sometimes really asking the question, like, they may be using cannabis because they're nauseous, but really the issue is that they're not, they're having a bowel movement once a week or twice a week or something like that. So you needed to sort of really aggressively manage their bowel regimen. So teasing out kind of why people are using it and what is some of the education you can do around that is really important. Next slide, please. So what about cannabis use during pregnancy and reporting to OCFS? So that depends on who you ask. This is kind of an ongoing, very complicated topic within the state of Maine. There's some work to overhaul the substance exposed infant notification process in the state. There's been a work group that I've been part of, kind of looking to change some of the legislation and sort of having high level legislation, and then kind of the specifics of how the process works, kind of at a lower level rulemaking process, so it's easier to change. Really hot topic. I mean, people, some hospitals report this, some hospitals don't. Some hospitals report certain patients, and patients will come to me and say, am I going to get reported if I'm using cannabis during pregnancy? And I have always the like unhelpful response of, I'm not really sure, because that's the reality of the situation. I don't really know. Is it one of the variables that might tip the scale? So sometimes if you have a situation, maybe with a past history of OCFS involvement or some other substance use early in pregnancy, or some other variable that might be a reason to be reported, and then you sort of add the cannabis on, does that tip it in one direction or the other? I think it's another reason why this really needs to be consistent across the state. So I look forward to kind of the rulemaking process on this to make sure that we're creating a very clear and concrete process, because when I am interacting with OCFS, it's confusing for patients too, because they'll say, I'll say, geez, we really want to cut back on the cannabis. Like, let's talk about that. Let's talk about impaired parenting. And sometimes the OCFS worker will say, well, it's no big deal. Like, it's just cannabis. I put that in quote because that's what people say. But as I talked about, with the potency increasing, the risk of paranoia, the risk of really severe impairment. And you think about severe impairment as a risk with, when you're parenting, regardless of whether it's alcohol or cannabis or opioids that is causing the impairment, it's the severe impairment that's a problem, not the specific substance necessarily that's causing it. So you want to sort of target that. And I've absolutely had people who are severely impaired by their cannabis. The other hard part is they don't necessarily look like they've used cannabis or smell like they've used cannabis per se, because they eat a lot of edibles. And so there isn't that kind of strong smell. So it's going to be hard to tease out what's going on here. It's really important if you have people that are using particularly edibles. This is a picture that I took from online because it really highlights that, edible marijuana products often look very appealing, right? Those little, fruit treats there in the picture I would like to have, right? They taste good. Lollipops, cookies, brownies, things like that. So making sure this is safely stored. We certainly see problems, obviously, when kiddos get into this, and they might eat a huge number of those candies because they taste good, probably. So safe storage is really important because we also know that pediatric patients are more susceptible to severe toxicity. Next slide, please. So what about the impact postpartum? So this was looking at, again, a pretty large study out of, I think this was California, that looked at those who had a cannabis use disorder. So those who used, a larger amount of cannabis during pregnancy, found that there was this incidence of increased infant death that was 1.4 times greater among those who had maternal cannabis use disorder. So that was a pretty compelling finding. They then went to sort of better identify what were the specific causes of death. And most were, related to an increase in sudden unexpected infant death. And so what causes that? And so probably what we're really feeling that is a major contributing factor here could be secondhand smoke exposure, for sure. I think it's impaired parenting. I think that's really more where we're feeling the reasons are. So could be impaired breastfeeding. So someone's using cannabis, they're in the middle of the night, they're impaired. They may fall asleep on the baby when they're attempting to breastfeed. Co-sleeping is a huge problem, again, because we want to look at, is the parent impaired? And then back up to like what's causing the impairment. Really, the question is the parent impaired? And if they're using a large amount of cannabis, they're sleeping in the bed with an infant in an unsafe setting, certainly you have folks who are rolling over on their children and suffocating them, and it's tragic. So it does seem to be related to sort of unsafe or impaired parenting. There was not an increased risk of infant hospitalization or emergency department visits. So it's not that there's sort of sicker kids out there, it's just that there's this increased risk in unexpected infant death. So we think that's probably related to impaired parenting in some capacity. Next slide, please. So breastfeeding, another really hot topic about cannabis use. So we're seeing more of it amongst women who are breastfeeding. It's really important to note that concentration of THC in breast milk exceeds maternal plasma concentrations. Depending on which study you look at, it actually can be a magnitude of up to 8 times greater. So it's a very, very lipophilic substance, as we talked about, and there's certainly a high content, fat cells in the breast and in the milk. And so it's really, there's you think about the sort of cannabinoids going into the breast milk, into the breast tissue, and being at much greater concentrations than even in the maternal serum. So there's probably a pretty dramatic increased risk of exposure through breastfeeding. Again, we don't know exactly the number, but it's increased, and it depends on the person. But so it's really important because, again, people, I think, don't necessarily think about that. They may think, oh, it's safe to use now because I'm not currently pregnant. We do know that peak concentrations in breast milk occur 1 hour post ingestion. It has a really long half-life, as I mentioned earlier, and it can take weeks to clear. There is not that much data around acute or long-term effects of exposure specific through breast milk. Again, one of the challenges there is how do you separate out potentially the impact of exposure during pregnancy from breastfeeding? Because I don't think you have that many people who were not necessarily using during pregnancy, but then start using specifically during breastfeeding. So we don't have good data on that. There's some conflicting results on infant motor development at 12 months. I think sometimes the most powerful conversation is, again, people don't realize how much more potent it is in breast milk. So trying to have that conversation with folks, because again, I think education is key. People are ultimately going to make their own decision, but I think if they have the information they need, they can make the best decision for them. It does likely decrease the amount of milk produced because it suppresses prolactin. And I just want to acknowledge, I said this sort of several times throughout the lecture, but assessing for impaired parenting is really hard. People ask me that all the time when I'm, working with OCFS or teaching classes, like, how do you assess for impaired parenting? Not easy, but you really have to consider impaired judgment, decision-making. So, things suggestive of poor supervision. If you're watching people in your office that seem to be impaired, they're not really supervising their child. Neglect seems to be present with the kiddo, or maybe they're driving under the influence, particularly if you have somebody in the office who seems to be impaired. They're about to get into a car with their child. Those are certainly big concerns. How's their mood? Are they really irritable? Is there evidence of psychosis or paranoia? And what is their insight into the consequences of use? So sometimes that can be helpful. Like if people really have seem to be impaired but are not able to actually see that there may be consequences to that. That's certainly a concerning situation and worth ongoing conversations and or referral to OCFS depending on the situation. Next slide, please. So patient information, I feel like the state of Maine was developing some information I meant to ask in advance, and maybe Hannah can speak to that after. This is a document that I found on ACOG, which I thought was kind of a nice bit of patient information if you want to be able to provide some information to your patient about what happens as a result of cannabis use during pregnancy. Next slide, please. So summary, cannabis use during pregnancy and postpartum is increasing and it's associated with adverse outcomes. Really important to discuss this issue with patients in a non-stigmatizing, non-punitive way. So again, we want to encourage folks to come in, to have a conversation, to better understand why folks are using it, trying to sort of tease things out, make sure they have the information they need to make good decisions, make sure that we are part of like improving that statistic that people trust their healthcare providers on this topic. So being able to talk about it in a non-stigmatizing, educated, informed, non-punitive way. And again, I think this is hard because patients are motivated not to tell you, not to talk about it because they're not sure what you're going to do with that information. So I really wish we from a societal perspective, that we sort of rewarded people for being forthcoming during pregnancy, not necessarily seeing that as evidence of substance use. That's kind of an ongoing dialogue that's far beyond the scope of this conversation, but I think it's really important. We don't want to in any way penalize folks for seeking care during pregnancy. When talking with patients about it, you can, some people will say, well, it's legal, therefore I'm just going to use it. It must be fine. And so sometimes I'll sort of turn that back on like alcohol conversation. If somebody says, I'm going to use it because it's legal, I'm like, well, alcohol is legal too. And we definitely don't recommend that during pregnancy because of all these things that might be associated with alcohol use. So you can kind of compare and contrast when somebody maybe puts that back and says, well, I'm, because it's legal. The other thing is, again, they may say, well, it's safe. It must be safe. I have a medical card. And then I try to contrast it to medications that are specifically unsafe during pregnancy. So like there's certain antibiotics or certain seizure medications or other things that we might use not during pregnancy, but they're associated with pretty significant birth defects during pregnancy. So I try to, sort of use that distinction. So like, yes, you have a medical card. Maybe it was appropriate during that period of time, but when you're pregnant, again, it's not something we'd recommend using, just like if you had a medication that was safe before pregnancy, but may not be safe now. I think preconception counseling is probably ideal. So when women come in for their primary care, their women, well woman checks, things like that, having conversations about cannabis use, alcohol use, really anything else. Because then you're able to have a conversation that there isn't that overlay of kind of fear of child welfare involvement. You can give them the information that they need, particularly from a preconception perspective. And that can be helpful for folks. And again, know your facts so patients can make informed decisions. We don't want to scare patients. We want to give patients good information. You have to kind of read the room a little bit. I had a patient yesterday that was using a lot of alcohol, and she could barely tolerate being in the room. So I'm not going to run through a list of all the things that might be associated with alcohol use, trying to sort of have that conversation about reducing use. What are some of the things that a person might need so that they can work to reduce their use of whatever they're using. And again, really trying to tease out why people are using it. and make sure that they have the appropriate information or education. If they've got this hyperemesis, and they're smoking more cannabis, it's almost certainly not helping. Again, if they're using it for anxiety, having the conversation around just really actually what we see long term is anxiety is worsening. There's these implications of cannabis use during pregnancy, and these are some of the other medications that we use for anxiety that are almost certainly safer in pregnancy. And again, things like constipation or nausea, nausea associated with constipation, to kind of try to tease out what are some of the other reasons folks might be using it. Sometimes people are like, I need it to eat, and it's really their reflux during pregnancy that's causing a lot of challenges. So trying to tease that out is really helpful, and just you can have an ongoing dialogue with your patients. But in no way do I want to suggest this is easy. This is probably one of the hardest conversations I have with patients, because people usually come to me with an opioid use disorder or stimulant use disorder with a very specific goal of reducing use, getting into treatment, not using as much of what they're using for a whole host of reasons. But with the cannabis piece, it's really they don't necessarily come to you with that interest per se. Many people don't perceive it to be a problem. So trying to sort of hit the right information at the right time while not discouraging people from coming into treatment is a fine line, or a difficult line to walk. And I've been doing it for 2 decades and I still struggle with it. So I want to just acknowledge that this can be a hard conversation, but coming at it with the right information can be helpful. And again, as with everything, when I'm talking with patients, particularly those who are pregnant, it's about sort of reducing. Like, it's not, people are not necessarily going to be able to stop using. Just any way in which we can reduce the intake of the substance is helpful, and celebrating those wins and getting them connected to resources is super important. So I want to be sure to leave some time. I think that's my last slide. There's a bunch of references. I did try to put the specific papers that on each slide if there's a particular topic you're interested in, but all the references that I talked about in this lecture are on I think it's 3 pages of references, so lots of references, and I'm happy to take some questions.
Thank you so much. Yeah, we have a couple questions. So the first one is, for many cannabis users who use to relax or to reduce anxiety or to stimulate appetite during pregnancy or postpartum while breastfeeding, are there appealing alternative relaxation, anxiety reducing, or appetite stimulating suggestions?
That's a good question. I mean, again, part of what I already talked about with some of the issues around, sometimes the appetite piece is reflux or GERD that we see a lot during pregnancy. The anxiety we have the conversation about, again, it probably makes it worse. I think counseling is super helpful. I think that the data supports that counseling for cannabis use during pregnancy is as helpful, certainly, as any kind of medications, which are not particularly successful. There's some evidence for gabapentin, but not much beyond that. And so I think I would probably refer to counseling and try to learn some of those behaviors with a counselor, relaxation techniques, and all those things would probably where I would direct folks.
Okay. And then in that same question, there's another question: are there handouts or stats that are particularly impactful to increasing motivation for change? Which I think you provided a lot of references.
Yeah, I think, I think I always say, and one of the biggest challenges to working with folks who are using cannabis is having the patient actually see that it's a problem. And so I think it often requires many conversations, and because again, they're not necessarily coming to you with the stated goal of. I get a lot of people referred to me for their cannabis use, but they don't necessarily perceive it to be a problem. So they're sort of like, why am I here? As opposed to folks who are kind of walking through the door with an opiate use disorder, who are really like, I want to get in treatment. I want to reduce my use. The perceived safety of it requires an ongoing conversation. Again, and trying to balance you don't want to sort of shame people or scare them. You want to have them continue to come see you, and sort of dancing that line or having that conversation can be very difficult. But there are some stats. There's, am I right-handed that there was some papers that the state was working on a document? I meant to ask you this before we got live, but that on cannabis use during pregnancy, or am I remembering that wrong? I could be.
Yeah, so we did create some resources which are finalized, but they haven't been printed or anything yet.
Got it.
So,
Okay.
but we also have the Good to Know campaign, and there's some information on there about cannabis use in pregnancy. So I'll put the link in the chat for that.
Yeah, and that link from ACOG is helpful. I think it just has kind of a broad-based information about it. I always sort of that picture with all the different ages of the children, like I find it effective, but potentially frightening. So, is it the right thing? I don't know. I mean, you can certainly pull it. I put the reference in. It really would depend on the context. But again, I think so many folks who come to see me started using substances because of untreated mental health issues or undertreated. And so there's really a strong connection to, I know how hard it was to have ADHD as a child. Would never want to, contribute to my child developing that because of what I'm doing during pregnancy. So that piece can be a kind of motivating conversation to have with patients.
Thank you. Another question, is there a recommendation to daily users who are breastfeeding to switch to formula due to infant impacts?
Oh, yeah. So I'm also not a pediatrician, so I should say that. But I think that, this is a tough one. I think if you look, there's not a single organization that recommends the use of cannabis while breastfeeding. So if you look at the American Academy of Pediatrics or ACOG or anything like that, I have not seen any organization endorse it. Daily use in terms of amount, I think I would probably recommend the person talking to their pediatric provider specifically. I don't think, there's certainly many benefits to breastfeeding, but there's a lot of cannabis clearly in the breast milk. So, I don't think it would seem in many cases that formula would be the safer alternative, but I think it's an individualized conversation with your pediatric provider. But I think that's another important place for folks to have the right information. So, it's not just OB providers or addiction medicine folks that are struggling to provide this information. It's really could be pediatric providers as well. So for folks who are, caring for the infant, to really have the information on hand that's the most accurate and the most reliable, and have some good teaching points as well. I mean, for me, I'd probably really try to work on, talk about the benefits of breastfeeding and really work on cutting back as much as you can, because I think that until people kind of tip into the use disorder, oftentimes they can, pull back their use if they understand it's a problem and it's not a use disorder, they can often reduce their consumption pretty dramatically.
Can you speak to the paternal contribution of cannabis use data on?
Sorry, I didn't mean to cut you off.
No.
That's a good question. In truth, I don't know much about from at conception. I don't really know about that. So that's a good thing every time I do a lecture, I learn of something that I should put in my next lecture. But I think that the paternal, some of the issues around unsafe sleep for sure has been, so making sure you understand who else is in the bed. You may have a patient and her infant who's doing great, no substance use, no concerns. But there's someone else in the bed who's using daily cannabis or something like that. And so if it's more than just the potential of the impaired mother, say, it could also be the other impaired parent, whether it's paternal or anyone else would be in the bed. So good to be aware of those questions and ask those questions.
Another question, do infants experience withdrawals if the mother used cannabis during her pregnancy? If so, what withdrawals are reported or documented?
Yeah, that's also a good question. I think I'm trying to remember. And again, I'm not a pediatric provider, so I should caveat that to some extent. We do, I think, see some withdrawal, whether it's I don't see a lot of just, kind of pure cannabis use for my own practice, but we certainly did see, I did a study looking at kind of folks who use cannabis and who were using opioids, and there did seem to be a worsening withdrawal when the two things were used together relative to the folks who didn't use cannabis. But exactly what those symptoms are, how long they last, I would not imagine that they were typically treated. But we certainly do see some symptoms that are probably somewhat similar. It's kind of like with stimulant withdrawal. It's kind of Not as clear of a picture as you see with opioids, but there's probably some withdrawal symptoms there. But I don't think I see, kiddos kept in the hospital specifically for cannabis withdrawal. I don't see that very often. It may happen occasionally, but it does seem to make it a little bit worse, at least according to the study we published, when there was cannabis use and opioid use disorder.
The dosage of THC varying so much each time a parent uses cannabis. Someone's asking, they know there's a chart of sobriety levels for alcohol. Does one exist for THC?
I haven't seen one. That's been a question that and if anyone actually finds one, I'd be quite interested in that. I was talking to some colleagues about that, and because I think this is a real tough issue for like judges and OCFS cases. Like, well, what's the right level, or what's a safe level or unsafe level? And I think, as with everything else, it's like, it's very hard to, when you have somebody who is using a substance, it can be hard to tell, like from a toxicology screen, for example, was it, a large amount that they used 6 hours ago versus kind of steadier, slower use over the last 3 days, something like that. So I haven't seen a specific number, although I've heard judges have their own number. Like if it's above 300, then that's concern. I've heard that. I don't know that that's necessarily based in science that I've seen. But I do think I get concerned for sure when I see patients really increasing because you can watch kind of the concentration, the urines that we do at the hospital have the total THC level, but then they normalize it based on like the how dilute or concentrated the urine is. So you can really see the levels specifically and compare, 3 or 4 urines over time, one that might be concentrated, one that might be dilute. And when those folks are like steadily marching up, it's concerning to me. And I usually try to really have conversations about that. And those are some of the people that have, developed the hyperemesis syndrome. And they, again, think, oh my God, I need to smoke more cannabis because I'm so nauseous and I can't, I feel so sick all the time. And really have no idea that the cannabis actually might be the contributing factor, not only not helping, but actually making it worse. And I don't think that's something that's really known. And I think probably obstetric providers are not that familiar with it. So they might be really aggressively managing the nausea, which is okay, like it's good, but, and not having the conversation about the cannabis use, which is concerning.
Thank you. We have a question about slide 7, which was the maternal impact of use, referring to greater risk of hypertension, preeclampsia, etc.
Yeah.
The question is the greater risk very significant?
So when you look at and I'm looking at pulled up slide 7, the adjusted risk ratio, so it's kind of a 1.17 increased risk. So if 1 was the sort of same risk, you can kind of use that number to sort of see, if it was 1.4, it would be a 1.4 times increased risk. So you could sort of multiply it times that. So sorry, I lost slide 7 here. So all, statistically significant and varying degrees of increased risk. It looks like the highest one was the placental abruption, actually, and in which was very close to the gestational hypertension, seemed to have the highest risk associated with it.
Okay, thank you. When we talk about cannabis, is CBD safer or better than having THC for mom and or baby?
Well, again, this kind of is dancing into the sort of like medical marijuana place. And so I want to sort of stay in my lane. It doesn't have the psychoactive effects. So at least from my understanding, the CBD piece. So from a concern about any of the implications on the mental health or the psychosis, that does not seem to be associated, at least as my understanding of the literature. And some people report that it's very helpful with pain. But I think for most of my patients, because I'm seeing in the context of the substance use disorder treatment program, the cross-reactivity that we see between CBD and THC is so high. I routinely have people say, they told me for sure I wouldn't test positive for pot, right? Like because they were given CBD, they don't want to test positive for THC, and they're angry almost, like they feel that they were not steered appropriately, right? And so it might be that in the final confirmatory testing it comes up negative, but there's a tremendous amount of cross contamination. And I have so many people that are involved in a drug court or say something like that, which cannot, that doesn't allow for the use of cannabis. So I think it's a muddy issue potentially. I don't, again, it's kind of from a pure CBD use. I'd probably direct somebody to a medical cannabis person who specializes in that. It doesn't seem to have the psychoactive effects, so that is less of a concern. But again, for my patients in the substance use realm of things, it can be complicated from a toxicology perspective, and it just sometimes brings unwanted attention that people don't want. Or they, send me a MyChart message saying, "Oh my God, I didn't use. I'm so sorry. I would have told you, but I didn't think I was going to test positive because it was supposed to be CBD." And so, which creates its own anxiety, right? Or people feel like they're being dishonest with their treatment provider, and we don't want any of that.
We have a question around hyperemesis, asking if it could be described as a rebound effect, using more to relieve the hyperemesis, and then after some initial relief, it returns.
It does seem to be cyclical, and so it seems to come and go, and then people typically use more cannabis because they think it's helping, but it then doesn't help, and it actually makes it worse over time. So it does seem to be kind of a worsening cyclical effect. And there's definitely an element to it as I think about patients who've described it. There seems to be more of an element of like pain, like than you would necessarily see with people who are the sort of typical, quote unquote, typical, pregnancy related nausea. Might be really just like, I feel like I'm going to vomit all the time, or I just feel like I'm going to be sick. I don't dare to eat because I'm going to puke. That kind of thing, as opposed to there seems to be an element of like almost aggressive puking or aggressive vomiting that has a real component of like pain, which is why we think in the hot shower, maybe because it relieves it pulls some of the blood supply away from the GI tract, maybe that reduces the pain. Again, that's not really well understood why the hot shower is diagnostic, but it does seem to be. And patients will often report that, like very specifically. They'll say, well, when I feel really, really sick, I get into the bath. And so that can be helpful information when you're trying to figure out. And again, you may very well have to manage the vomiting and the nausea itself while people are coming, pulling back on the cannabis use. It doesn't, you certainly can use all the same modalities that you would use to treat regular pregnancy associated nausea and vomiting. But the real key is to get folks to reduce their cannabis use. And it does eventually make it better. It can take time.
We have one more question, a little unrelated, but do you know what substances have to be being used by pregnant patients have to be reported to OCFS?
So, as the statute's written, and there's probably people on this call who could recite the statute better than I can, but it basically says any substance exposure during pregnancy that creates a withdrawal syndrome or requires, I'm trying to think of exactly what it says, it requires like ongoing monitoring that's outside of sort of quote unquote typical newborn or fetal alcohol spectrum, the sort of these other pieces. And so there's a lot of conversation, and I think that's why there's work ongoing about how to really write that into the rules, because it should be consistent across the state how we're interpreting these rules, right? So there's some hospitals that feel cannabis should be reported, maybe because it does have a withdrawal syndrome associated, maybe because it doesn't. I think it's people don't really know what to do with it. It's legal. People are acquiring it legally, so it's not an illicit drug, so it sort of doesn't meet that category. It's very hard, and so I think I'm looking forward, honestly, to writing the rules or helping write the rules on this topic, because I think it's really important that I don't like saying I don't know if you're going to get reported, right? Because that doesn't make it look like And so I would really like to be able to say, well, these three things would get you reported or not, right? A very consistent kind of algorithm of how it might be impacting your life. So some people interpret yes, some people interpret no, some hospitals do. And that's tough. Like, you don't want to say, well, if you have your baby at this hospital, yes. If you have your baby at this hospital, no, because that just really doesn't make a lot of sense from a state perspective. So I think there's a lot of conversation about that law in particular. I would say also because it requires, if you have a patient that's in treatment for years for an opioid use disorder, no returns to use, anything like that. They will still have a baby that has a withdrawal syndrome. And, that in my mind, as Elaine O'Connor, speaking as somebody who works in this field, not necessarily on behalf of any organization or state, I don't believe that those folks should be reported. They're not any different than any other patient that is on a medication for a chronic disease. And there's no concerns present for abuse or neglect, then I feel like we should be honoring that they're in treatment for their chronic disease, as they would be if they had depression or anything else. And there are, again, psychiatric medications that cause a withdrawal syndrome. So this is a very complicated topic, and I look forward to having it be more specific, both so that providers know what to do and also so that patients have an understanding and an expectation of what's going to happen to them when they deliver their baby, because they're entitled to that.
Great, thank you. There's one more question, but I don't want to keep you any longer because we are a minute over. So maybe we'll email you the question and we'll get the answer out.
Yeah, feel free to give my email out too as you send.
Okay.
I don't know if you send all this stuff to participants, what have you. I always mean to put them on my slides, but I always forget. So,
well, thank you so much. We appreciate your time and you being here. This was great. And we will send evaluation certificates, slides, everything in email form so everyone can have all this great information.
thanks for coming, everybody. I really appreciate it.
Thank you.
Thank you. Have a great rest of your day, everybody.